So thanks again for inviting me to speak. I got to speak to some of you last year at the annual conference when I was just starting out this project. So hopefully there will be some news to you. Some of you, I apologize, you'll be hearing this again from my faculty. So during my time at Emory, I did research as a graduate student looking at primary care physicians and their referral patterns. So first, I just want to start out with some background literature. PCPs are often referred to as the gatekeepers of genetic services. We know that many patients could benefit from many different types of genetic services, whether it's having genetic evaluation, risk assessment, genetic counseling, ordering of genetic testing, interpretation of genetic testing results, and psychosocial coping with either the risk or diagnosis of a genetic condition. And specifically, that could lead to a diagnosis. It could help manage precision medicine and guide specific treatments. It can also initiate familial risk screening based on a known risk in the family, guide reproductive decisions, and however, for patients to benefit from these services, physicians need to first be aware of all of the available services and secondly, be able to utilize them appropriately. Next slide. Okay, so looking at the recent literature, and recent being maybe over 10 years ago, how do physicians perform in terms of using genetic services? Well, there's evidence first for Bellcross et al. 2011, looking at hypothetical clinical scenarios when presented with different cancer situations. 45% of physicians would choose to order genetic testing, specifically for BRCA1, for low-risk patients, so low risk based on the U.S. Preventive Task Force guidelines at the time. And on the flip side, we also see underutilization. So Trivers et al. 2011 showed that, again, hypothetical clinical scenarios, only 41% of physicians would order cancer testing for high-risk patients. So there's high-risk patients that would have missed out on genetic testing that they would qualified for. And it's not just strictly in the cancer genetics setting. A more recent study in Canada looking at hypothetical clinical scenarios and global developmental delay found that only 21% of pediatricians would initiate any sort of genetic testing when presented with a case of GDD, or global developmental delay. Furthermore, when you really try to hit them in the head with it, they presented another case of a girl with GDD and a known family history of Fragile X testing. Only about 56% of those physicians would have ordered Fragile X testing for that case. And so with these errors or underutilization, this can lead to adverse events. This has been well documented in the literature through a case series of studies. And they have identified at least 30 different cases where a delay or failure to refer out to genetic services has led to incorrect genetic testing ordering, incorrect interpretation of results, and unnecessary procedures in clinical decisions, as well as incorrect genetic testing information. So you have probably heard this for those of you practicing. Many times they've reported at least 5 cases here of patients proceeding with bilateral mastectomies, hysterectomies, oophorectomies, based on variants of uncertain significance from testing. So typically we treat those as clinically negative. Patients should not be making medical management decisions based on a VUS. Another story was a patient who was positive for a pathogenic familial adenomatous polyposis syndrome. that doctor, returning the result, recommended the patient to receive hysterectomy and oophorectomy, which she did. And we know that that disease and that gene mutation has no increased risk for uterine or ovarian cancer. So unnecessary procedures, well documented in the literature as well. And kind of more on a positive note, if they don't receive genetic services, there's missed benefits both to patients and providers. So the United States Preventive Task Force did a systematic review. They identified 28 studies showing that genetic counseling was associated with reduced breast cancer risk, worry, anxiety, and increased understanding of knowledge. A second study by ARUP, the genetic testing lab company, piloted a testing review system where genetic counselors would review tests ordered by other physicians at outside institutions. And they found that 26% of those tests were modified by the genetic counselor, whether it was just canceled, changed, or additional testing was added. And based on that, they estimated that this would save those ordering institutions $48,000 a month. Next. So many studies have also tried to look into the most commonly reported reason, of course, is knowledge level. I didn't put any studies here because it's been very well documented. And not surprisingly, tied with that is comfort level. So physicians who are more comfortable ordering testing are more likely to do so. And an effort that has been brought up over time and time again is improving non-genetic physicians' education. So there's been efforts, particularly in some studies have showed that more recent graduates have higher genetics knowledge. However, it's not always consistent with their utilization. So another study showed that, yes, they do have increased was perhaps they were more aware of the complexities of genetics and therefore less comfortable. And so it's not a one-to-one interaction of just increasing knowledge, increasing comfort level. It's more complex than that. And furthermore, in terms of after medical school, there's been efforts as well documented in the literature to increase practicing providers' genetics knowledge. And 2 studies have shown it does help. It increases their genetics knowledge, but it didn't change their utilization at all. So to kind of change gears from focusing on providers, moving to patients, actually when we look at association studies, the greatest predictor has been found to be patient interest in inquiry. So if they actually bring it up with their physician and initiate the interest on their behalf. And something interesting about that, Shields et al. 2008, showed that minority serving physicians, so which they defined as physicians who had 50% or more population of minority patients, were less likely to utilize genetic services. So we need to consider both provider and patient factors. And overall, these studies together show that it's pretty complex and elicits a need to better understand how all of these factors together influence referral patterns. Next slide. So the aim of my graduate research was to characterize referral patterns one or two, maybe more recently. So there's a lack of data in our current genomics landscape since we commercialize NGS, since whole exome sequencing costs has come down, panels are more frequently ordered. There's no data during this time period. So the other thing is that there's no data on how often physicians are actually ordering. We haven't been able to really quantify how often they're referring out or ordering testing. And along with that, we also aimed to characterize them in terms of what factors are actually influencing their referral patterns. Is it patient demographics? Is it provider demographics? What year they graduated? What kind of practice setting they work in? As well as barriers. What do they think from the physician standpoint are barriers to them being able to access these services and for their patients? And overall, the end goal is to hopefully inform efforts to improve genetics utilization, whether it's through education or other means. Next slide, please. So how did I perform this study? My team and I developed an online survey. It ended up being 34 items, and it was initially reviewed by a few geneticists as well as beta tested by several physicians and fellow students at the time. We were able to obtain some funding to incentivize our participants. We made a raffle to make available $100 Amazon gift cards, only 10. And sorry, my slides got a little bit jumbled up, but our main population was actually PCPs across the US. So our initial method was to go through listserv through the American Medical Association. And our sample was about 4,500 pediatricians and non-pediatricians. We stratified that to ensure we would get physicians from both types of populations. And unfortunately, that response rate was much lower than we expected, so we expanded out to more personal networking and online networking, primarily focused within the greater Atlanta area. And lastly, we tried social media recruit through Twitter. Next. And as part of the survey, we also presented clinical scenarios, asking the PCPs what they thought was the best next step. And we decided that we also wanted to compare their responses to clinical geneticists. So at last year's conference, I was able to recruit a good amount of clinical GCs. I see some of you in the participant list today, so thanks so much. And then we also continued that recruitment through snowballing online networking as well. Next. And so how did we actually analyze our data? Next slide. So as I mentioned, our survey asked several different questions in terms of demographics for physicians, what year they graduated, what their primary specialty was, what their practice setting was. And practice settings included if they had a genetic counselor in practice, were they in rural, urban, suburban, academic centers, private practice, etc. And we also tried to characterize a little bit of the patient population by asking the physicians to give us an estimate of the proportions of non-Hispanic white patients they serve and non-English first language speaking patients. It's kind of worded differently because we tried to get at kind of the complexities of what we would define maybe as ethnic or racial minorities. And outcome variables, as I mentioned, we asked them how frequently they would order genetic testing or refer their patients out to genetic services. We ended up using medians mostly for our measures because the data ended up being a little bit skewed. And for genetic testing, which I'll point out in just a second, the kind of median for that was actually 0. So instead of looking at numbers for that analysis, we just divided the physicians into 2 groups, whether they had ordered genetic testing or not. And so we asked them this over a time span of in the past year, how often they would do this. And we also tried to assess what their motivators were and what their barriers were. And on the right-hand side, I just list different statistical methods that we used. Next slide. Okay, so our results, just to show you the demographics of our respondents. Overall, we had about, I think it was like 95 participants respond, of course, not to every question, so you'll see the N changes. Majority were pediatrics, however, not by much. We did have a good group in either family practice or general practice. Others were either internal medicine or med peds. Next. It was mostly female. Next. And mostly American PCPs as well. And I mentioned the 2007 as a kind of a landmark year for medical schools education curricula. And so we divided them into whether or not they graduated before or after that year. We had a good spread, see the median sort of in the middle of the spread. However, most of them were younger or graduated more recently. And age, we also had a pretty good spread. Next. In terms of what their practice demographics looked like, again, because of the way that we had ended up recruiting most of our participants, about half of them were from the SERGG region, which I think is probably good for this group and the data that we could look at. And then practice location, most of them were suburban. And I just want to point out, again, apologize that the visuals are a little bit off. Most of the physicians, 70% or so, were actually within 30 miles or less of a genetics facility. So if you've ever talked about this topic, something that is always cited is distance. For our group here, you would think it shouldn't be a big factor. Next. Practice setting, we had kind of a variety of different practice settings. There wasn't one that was predominant. We tried to ask about telemedicine patients. Not many have that practice, and a majority do not have a genetic counselor in clinic. So 84% no. And it was interesting is actually 5% aren't sure. So again, talking about awareness of resources. And then the patients, most of the patients, about 50% were non-Hispanic white, but most of them were English speaking. And then we also, in terms of trying to calculate referral rate, asked the physicians how many patients they see a month, and then multiply that by 12 to get annual. So of course, one of the limitations here is, they might see a patient more than one time in the span of a year for follow-up appointments, et cetera, but I'll address that when we talk about the results. Next. So overall, the PCPs referred a median of 3 patients with a range of 0 to 20. And as I mentioned before, they ordered a median of 0 tests per year. And that range was 0 to 15. I will say the higher end was much less common. It was more skewed, left skewed for both referrals and genetic testing. These are the purposes for either the referrals or the test. Nothing super surprising here. Most common reason for diagnostic genetic testing. Next. So then we tried to look at the different demographics that we had asked about and see if there were any significant associations. And we actually saw 2. So first looking at the green and orange histograms or box plots here, we found a significant association with referrals based on whether or not they had a genetic counselor in clinic, where those with genetic counselors were more likely to refer out. And the next second association was with PCP race. So we found that white PCPs, shown in the gray box here, were more likely to refer compared to Black PCPs. And that's when we did kind of post hoc analysis between the three different groups. And then we looked at their patient populations to see, are there differences in physician race and patient population? And in fact, we did see that white PCPs are less likely to serve minority patients. So overall, their proportions were 21% less minorities than Black PCPs. We did not find any significant associations with genetic testing rates. So again, overall, the median was 0%. If you look at the right-hand side for physicians who actually did order genetic testing, the median is less than 1% a year. So it's very low. Next. Looking at motivators and barriers, these are just the top 3. They were allowed to select more than one answer, so you'll see it adds more than 100%. The most common reason to refer out was that they preferred specialist coordination. It's about 55%. Coming in at 33%, they lacked the specific knowledge base. And 30% of them were based on patients' desire to learn about relatives' risk information. In terms of barriers, the most common barrier was actually patient refusal at 46%. Second most common is concerns about financial costs of the test, and that was about at 37%. And 24% were just unsure of when a referral would be appropriate. So that's about a quarter of our sample. Next. And just because this is something of great interest to the SERN group, in terms of how to improve education, we asked them what resources they prefer to be able to stay up to date with genetics. I just want to point out one that common reason is or common preference is to have a genetics consult, whether it's formal or curbside. So they would like to have a provider in genetics available to them. And 86% of physicians responding to this question chose 2 or more methods. So it's not just one method that we need to focus on, but several. Next. So what are our conclusions from this study? Apologies again for the slides. So PCPs overall are referring more than they are ordering genetic testing, but both at very low frequencies. This is consistent with the one other study that we found looking at quantification, and they found that on average physicians were ordering 0 to 3 tests a year. Next. And sorry, this came out tight. A large proportion of our PCPs said that they lack knowledge of or are uncertain when a genetic referral is appropriate. So again, we see knowledge as coming out as a factor, which is not surprising. I listed several different studies that have pointed that out as well. And we also need to consider additional barriers outside of distance, because here again, the majority of physicians were within a reasonable distance to genetics. When they have the knowledge, even when they're aware the services and initiate that referral, there's still barriers beyond that. And those are more systematic barriers beyond our control. Next. I wanted to point out really quickly our finding with physician race and patient population race. That's consistent with the study I quoted before, that minority serving physicians were less likely to order or refer out. And then there's many studies looking at patients too, and how they're less likely to uptake genetic services. Next. And I think the main point that I want to harp as a genetic counselor myself is looking at genetic counseling as a resource for PCPs. So there have been pilot studies that showed that this is a sustained method PCPs continue to use after the initial pilot study. It helped decrease in-person visits after genetic counselors were consulted for potential referrals. Next. And then I just want to point out that something that you probably all know is that there's a huge demand, but there's not enough providers, whether it's geneticists or genetic counselors. So 2 geneticists for every 1 million patients. I am out of time for study limitations. Sorry, Teresa. So I'll skip past this. Some of the future directions, I just want to point out that Dr. Eileen Kennison is looking specifically at statistics for the SERN region, and we'll be publishing hopefully a second manuscript looking at the hypothetical clinical scenarios to actually assess their knowledge. I'll skip the rest of this slide. These are my acknowledgements. Thanks so much again to Dr. Singh for this opportunity, my team, Joint Counseling Training Program at Emory. And since I'm out of time, maybe I'll ask to see if I have any questions.
I don't have any questions, Sheena, but I do have some comments. This is Curtis Rogers. I work for the Greenwood Genetics Center.
Sure.
I think one thing that has helped us as far as referrals is the fact that even though we're in a city, Greenville is not large, and have trained in our program in Greenville and then gone out into the community. Many of them have stayed, so they are very familiar with our genetic service, and we know many of them on a first name basis, having helped train them. And I think that always promotes discussion and referrals about clinical evaluations and testing. We are fortunate in that way. If you live within 30 miles of Greenville, South Carolina, a genetic center, that is much different than living within 30 miles of a genetic center in Atlanta or New York City. So I think we have to keep that in mind. I'm a strong proponent of utilizing genetic counselors, and in fact, they screen our referrals, and sometimes we'll contact the physician's offices and say, hey, this patient probably does not need a referral, and will help facilitate testing prior to the patient being seen at our office sometimes. I think if we're going to promote education, being from the South and a redneck, I think we have to realize sometimes even physicians are what I call hard to learn. So they don't want to learn information that is not pertinent to their medical specialty. Therefore, I think you need to target those particular medical specialties. I'm going to pick orthopedics for one, since we have a Shriners Hospital in Greenville. When I go in to talk to them, and I'm recommending to them, you don't need to send every patient with hypermobility to see us. I think we need to give them and educate them on things that they can do, because they're going to have patients who have a positive family history. And I think we all want to make sure that there's not something we're missing, Marfan syndrome, Loeys-Dietz, whatever, some type of severe Ehlers-Danlos syndrome. I think we need to educate them that they can order a panel, that if the panel says negative, that's great. If there are questions about the panel when they get the results, that we are certainly available, as are the genetic counselors, to answer those questions. So I think we need to focus on panels. Whole exome sequencing for non-geneticists, I think, is a no-go, because I just think it overwhelms them, because we're going to find something in everybody. But I think if we can target them with panels specific to their specialty, whether it's skeletal dysplasia panel or EDS panel or connective tissues disorders panel, an ataxia panel to the neurologist, we can get them to order some of those tests and therefore screen out some of those patients and help us. And we may see the patient only to discuss the results and long-term prognosis, which is our area of expertise. So I think that's where we need to focus our efforts.
Yeah. So I think maybe we will end this at this time because of the time. But Dr. Rogers, we could use your guidance in the region to see how we should be communicating to the PCPs. That's one of the challenges, I mean, you have it in South Carolina in your program and things, but it'll be very, very interesting to keep your wisdom to the group here.
I think the other thing is we're having there are private groups now that are being funded by pharmaceutical companies to provide information, and I'll use one in particular for lysosomal storage disorders to make slideshows available and directly contact primary care physicians to provide that information, and then allow them to access a geneticist to discuss with further should they have that need. So
that's a good model. Okay.
All right, if we don't have anything else, thanks Tina and Dr. Ziad. This will conclude our SERN SERGG Lunch and Learn for today.